Okay, good morning, good afternoon, good evening po sa lahat. Saan mo pong panig kayo ng mundo naroon. Welcome to our 243rd episode of the Health Updates webinar program brought to you by the University of the Philippines. Thank you for being part of our credible online community. And to all those who just discovered us today, welcome po. At sana po marami po kayong matutunan at marami po kayong maibahagi sa inyong mga makakausap nyo, pamilya, kamag-anak, mga kaibigan po no, sa ating topic for today. I'm very happy to be back. I was just attending a conference from last week. Now, I'm very glad to be able to join the team. And today po, napag-uusapan po natin ang tinatawag po na chronic coronary artery disease at ano po ba yung mga alternatibo pong mga treatments para po dito. So, as we are in an era wherein there are tumataas po, dumadami. Global burden of cardiovascular disease, katulad kasama na po yung chronic coronary artery disease. Meron po tayong significant public health concerns and challenges that demands a continuous re-evaluation kung paano po ito gagamutin. At mayroon na po tayong mga established po no, ng mga pharmacological interventions at saka mga revascularization procedures po. No? These are cornerstones of management. Pero po yung dynamism, yung pong constant na pagbabago ng pong cardiac care, kailangan po na mas maigi pa po at mas maigting pa po ang ating pagkakaintindi, especially kung may mga emerging po, less conventional na makakatulong, evidence-based pa rin naman po na alternative treatment modality. So for our episode this week, we'll be bridging po no, existing knowledge gaps that we may have, fostering a comprehensive discussion on innovative strategies in the long-term management and treatment po of chronic coronary artery disease. We'll be exploring po ano po ba yung mga therapeutic avenues beyond the conventional approaches. Maybe there are novel pharmacological agents na pag-uusapan. Ano po ba yung mga pwedeng advanced lifestyle interventions, integrative therapies. Lahat po ito basa rin po sa sensya. This is the Health Updates program and I'm your host, Dr. Raymond Francis Sarmiento. Always a pleasure to be with all you during our regular Friday. Also my pleasure and honor to host this program together with Dr. Stella Mariose. Ma'am Stella.
Good afternoon, Raymond, and to all those watching, our participants here in the live broadcast of the Zoom webinar, and to all those watching via live streaming on the TVUP YouTube channel, as well as the UP System Facebook page, the TVUP Facebook page, and of course, all those watching from TVUP Signal TV channel 101. Joining us this week is Dr. John Añonuevo, our cardiology expert and the chair of the UPPGH Department of Medicine, and Dr. Eric Oliver Sison, who is the chief of the Cardiac Catheterization Unit at the Philippine General Hospital Department of Medicine. Their presentations will dive into the physiological underpinnings, clinical indications, efficacy, safety profiles, and of course, patient selection criteria pertinent to these modalities, which help ensure a balanced and pragmatic perspective. In this week's episode, we can optimize patient care pathways, especially for chronic coronary artery disease patients. But before we go to the presentation proper, let Raymond will introduce our person on the street video.
Thank you so much, Dr. Stella. And you're seeing on the screen po, no? Welcome. One of your favorites po, no? One of the best cardiologists that we have in the country, Dr. John Añonuevo. But before we dive into the webinar proper po, no? We'll have the person on the street video for additional context lang po. Ano po bang alam po natin patungkol po dito? And the questions that we pose to our interviewees are as follows. Ano po ang alam ninyo sa kung paano ginagamot ang mga taong may baradong ugat sa puso? Sa alam po ninyo, ano-ano ang mga iba't ibang pamamaraan at alternatibong pamamaraan upang matanggal ang mga bara sa arteries sa puso. Maliban sa angioplasty or bypass surgery, may alam pa po ba kayong ibang pamamaraan? At sa alam po ninyo, ano-ano po ang mga dapat gawin upang maiwasan ang pagkakaroon ng sakit sa puso? Please watch.
Yeah, I generally do not know much since I don't have a close relative or anyone in my family going through any heart-related diseases. But
sa mga nakasama ko sa trabaho ginagawa nila yung parang bypass operation. Operation parang binubuksan surgery ganon sa dibdib nila sa puso.
Usually yung father ko nagkaroon ng I think mild na heart attack. Tapos na-observe doon na kaya nagkaroon ng chest pain kasi meron pala siyang bara sa ugat sa puso.
What I have heard about it is there are bypass procedures, and I think there's something na pinapasok dun sa loob ng arteries to get it. So, something like a grabber. That's all I know.
Siguro most of the more critical ones, heart attacks or all the vices or any habits, eating or dietary habits that would lead going to the heart-related diseases.
Sa ngayon po hindi po ako updated kung anong klaseng surgery o anong klaseng paggamot ang ginagawa nila ngayon.
Nag-angiogram muna and then nung mukhang like okay siya mag-undergo ng procedure, nag-proceed with angioplasty. So yun yung naglagay sila ng mga stent para lumuwag bale yung blockage dun sa mga ugat para ma-clear tapos magkaroon ng pathway, maluwagan yung ugat kumbaga.
Siguro po healthy lifestyle lang para sa katawan natin. Iwas mga alak, sigarilyo, kung ano pang bisyong masama sa katawan.
Yeah, I think that's all that I know at this time.
So, hindi ko lang to sure kasi hindi ito yung pinagdaanan namin, pero I think baka siguro sa preventive or like kung meron kang risk, baka mga blood thinners siguro. Pero hindi ako familiar enough with them to explain in detail. Pero ang intindi ko dun is parang, yeah, I mean, blood thinner, para pinapanipis na yung pagka-clog, yung pagka-anong quality ng dugo na mag-clog.
I'm sure, look, first and foremost, the diet is really important. We would like to reduce fats or cholesterols, those that are involved in restricting blood flow or the ones that may accumulate around the heart area.
Pinakauna talaga, although magmumula talaga to sa like kung may self-discipline is maging alerto at umiwas sa mga food na may tendency makabara sa sa mga ugat. Not necessarily lang sa heart, pero yun yung pinaka di ba? Since yun talaga yung daluyan ng dugo.
Siguro po kailangan natin ng maayos na tamang oras sa pagtulog, kung ilang oras ang dapat sa ating katawan at iwas tayo sa mga matatabang pagkain.
Iwas ka sa mga fatty, sa mga sugary, kasi diabetes factor din yun. Maging active para ma-burn yung mga yung mga excess fat na pwedeng maging blockage in the future. Maging active.
I think it's more of the food that you eat. So it's like diet, less salt and less cholesterol, I think.
Hindi mo naman need na syempre mag-over-excess ng mga yon na iba naman yung aabutan mo doon, pero yung proper management ng abstain saka ng pag-intake, hindi naman sinasabing bawal, sinasabi lang na mag-ingat.
Okay, thank you so much po to our webinar team. Marami naman po palang kaalaman ang ating mga na-interview and hopefully we'll be able to learn a whole lot more in today's episode. Before we proceed, a little bit of housekeeping. We have already sent out all of the certificates of attendance for those who have watched at least 50% of the webinar duration. Lahat na po ito for our 242 episodes. If you have any questions or you have any comments po, any feedback, those are all welcome. And you can just email us at our up.edu.ph email address. For our webinar today, we'll be having a standard panel discussion format, and after speakers have presented, that will be followed by a Q&A session. We'll now proceed with the topic at hand for our webinar. We'll get it underway. Dr. Stella Ocel will introduce our main speaker for today.
Our main speaker is Dr. John D. Añonuevo. He is a graduate of the UP College of Medicine and was a magna cum laude in pre-med. He is my classmate, and also he is one of the best cardiology consultants in our country today. So to present this afternoon, we have cardiology consultant and chair of the Department of Medicine at the UP-PGH UP Philippine General Hospital. We have Dr. John D. Añonuevo.
Good afternoon, everyone, and thank you again, Stella and Raymond, for inviting me again to be with our listeners. And it's interesting that this time I will be talking about the non-conventional treatment of coronary artery disease. Raymond, I was listening to the people who were interviewed, and you're right, no? I think a lot of them already have knowledge on the conventional treatment for coronary artery disease. Uh, Bypass and angioplasties have been mentioned, and then other lifestyle modification. But this afternoon, I will share with everyone some other treatments that we are not commonly aware of. These are the non-conventional treatment for coronary artery disease. And I have invited, and we have invited rather, Dr. Eric Sison. Siya yung chief ng cath lab ng PGH. But we will not be talking about bypass and angioplasty this time. I think I've talked about that, I think. So let me just share my slides. Okay, I'll share now. Just let me know if... Okay, I'll put it in that. Okay, are you able to see?
There you go, sir. Yes, go ahead, sir.
Okay, so we'll start. So as you can see, the title is Iba Ito, Alternative Treatments for the Management of Chronic Coronary Artery Disease. These are my disclosures. Our objectives are as follows. I will try to share with you some new concepts on what we call chronic coronary artery disease, or now we call it chronic coronary syndromes. And then, as I have mentioned, we'll discuss some pharmacologic therapies that are less conventional and I would say a little bit novel. And lastly, we'll look at some adjunctive therapies other than bypass and angioplasties that we can use nowadays for management of chronic coronary artery disease. My sources of information are the latest 2023 guidelines from American Heart Association and American College of Cardiology, and the most recent 2024 European Society of Cardiology guidelines. So let's start with basic definition. It's always important to understand what we mean by chronic coronary syndrome and coronary artery disease. So if you look at the definition of CCS, this is the new terminology that we use now. This was recommended in the last 2019 European Society of Cardiology guidelines. When you say the patient has chronic coronary syndrome, that means clinical presentation of the disease, which is coronary artery disease, during stable periods. This is in difference to the patients with acute coronary syndrome or acute myocardial infarctions. Those patients who are suddenly rushed to the emergency room with severe chest pains and then they have an acute heart attack, in layman's word, no? But these patients that we call chronic coronary syndromes, they are stable patients. They have the diagnosis, but they are not actively having major symptoms of chest pains or any form of angina. While coronary artery disease is the process, the pathological process that is characterized by most of us, what we know, the accumulation of atherosclerotic plaque in the big arteries or the epicardial arteries of the heart. Ito yung pag sinabi ng doktor, may mga barado kayong ugat sa puso. That is basically what we mean when
Nawala yata yung connection
I
ni
think
John.
yes.
Oo.
We'll wait
So let's just wait for a while to our
Dr.
audience.
Jan.
Dyan lang kayo. Stay put. Huwag kayong umalis. Babalik din yan.
Maganda pa
Sorry
naman yung,
about
yung
this.
build up ni Dr. Jan.
May mga technical glitch that we cannot control. And this is one of them. So, maganda yung topic niya, no? So, I hope he comes back.
Ma'am Stella, what is our for next week? What will be our last topic for the month of June?
For next week, our our speaker is a very interesting person, si Tony Dance. Oh, so
Okay.
yeah, ito ibang usapan to. So anyway, Tony Dance is a very good speaker. He's also the class president of Class 83. So marami rin tayong matututunan dito. He's also a cardiologist pero he doesn't want to speak on cardiology kasi John is already speaking for him. So ibang dimension yung kanyang talk. So
Okay,
next
okay.
week, stay tuned to us. We have a very interesting topic.
That's
So
good. That's
let's
good.
wait for John, or do you want to yung ating mga, di ba meron tayong mga pinadala ng gifts, yung ba na ano
Yeah,
na.
I think those who are asking kung matatanggap po nila, I think we have already, well, slowly started po, no? May kailangan lang po kasi kaming logistically ayusin patungkol po doon sa mga tokens that I'm talking about the 5th anniversary tokens that we have. So
Ayan.
yun po yung hopefully if you have received
Hello,
them, then
Raymond.
maybe you can take a selfie and then share it with us. And then ano po no, we'll also continue to monitor and track that everyone who has signed up to receive it will be able to receive. I see Dr. John Nuevo is back.
Okay, so he's back. Sige. Thank you, John.
Is still ano,
Sige.
is still
Wait, sorry, we had
there we go.
problem with the we had a problem with the signal. Wait, hold on. Can you hear me?
Yes sir, loud and clear.
Okay,
Yes,
I'm sorry.
loud and
I'm sorry
clear.
about that. Okay, now,
Okay.
so as I was going through the definition of coronary artery disease and chronic coronary syndrome, let me just review again what we know of coronary artery disease. In this slide, you can see that it pertains to narrowing of the arteries. You can see here plaques developing, forming inside the coronary artery disease, inside the coronary arteries rather. But I'd like to explain to you the new paradigm of what is called now chronic coronary syndrome. It does not only pertain to coronary narrowing of your arteries in the heart, no? There are other concepts that have been discovered that can cause myocardial ischemia. It is not exclusive for the patients with obstruction in their epicardial coronary arteries. You can see here that inflammation, endothelial dysfunction, even microvascular dysfunction, I will explain that in the next few slides, or vasospasm can cause myocardial ischemia other than those patients who have critical coronary artery stenosis or narrowing. Just to explain to you what we mean by that, this is a picture, as you can see, of a patient who had a coronary angiogram. You can see the large epicardial coronary arteries. But do you realize that that only comprise 5% of the total coronary vascular tree? This is what we have. These small arteries, which is called microvascular vessels, they are not seen during coronary angiogram. So there are patients who might have normal, large epicardial coronary arteries, but will have problems in their smaller vessels who would present with typical anginal pains. But their coronary arteries, the large ones, are free of narrowing. So this is what is accepted now. There are microvascular, the large arteries that can cause angina, but a big chunk, almost one half or 50% of patients with chronic coronary syndrome will have disease in their smaller arteries that we don't see during coronary angiogram. These are patients with microvascular dysfunction. And this is a slide that tells us that there are multifactorial causes of myocardial ischemia and angina involving the epicardial, the large coronary arteries, and the coronary microcirculation, the smaller arteries. But on top of these two, even the cardiac cell the cell itself, the myocardial cell, can have problems like transcellular, intracellular, and even mitochondrial dysfunction that can lead to myocardial ischemia. And all of these three mechanisms can overlap. So, in summary, for this pathophysiology, we need to realize that not only epicardial or large coronary arteries can be responsible for myocardial ischemia, but even in patients with microvascular dysfunction or cellular dysfunction can lead to angina and myocardial ischemia. The goals of therapy when we see patients with coronary artery disease, chronic coronary syndrome, would be one, improve their quality of life, improve life expectancy, of course, and also reduce the risk of morbidities like non-fatal ischemic event, progression of the epicardial or microvascular chronic coronary disease, and symptoms and limitation caused by chronic coronary syndrome. And these are some of the strategies that we can use in the management of these patients. Very commonly, we use anti-anginal agents. Of course, most of these patients that would carry the diagnosis of coronary artery disease would have drugs that can lower their cholesterol. Aspirin or other substitute for aspirin are needed for antithrombotic strategies. And I will be talking to you some non-conventional therapies like metabolic enhancers and the newer drugs for diabetes, the SGLT2 inhibitors and GLP-1 agonists, as well as some anti-inflammatory drugs. If you look at my previous slide in terms of pathophysiology, and inflammation is one of the key concepts now that are being used in terms of its possible relationship to myocardial ischemia and angina. And there are some anti-inflammatory drugs that may be used to combat these problems. And a special discussion on chelation therapy, because there are quite a number of Filipinos who end up having chelation therapy for coronary artery disease. And of course, on the other side will be your surgical or percutaneous revascularization in the form of angioplasty or PCI, CABG, and then some of the less used intervention. And I will be having some slides on that also. ESMR, EECP, and transmyocardial revascularization. Let's start with the very basic, the medications that we use to control angina. Most of the listeners would probably think of beta blockers, calcium channel antagonists, and nitrates. These are commonly used. They affect the blood pressure or the heart rate using the principle of supply and demand. The less supply you have, the patient becomes more ischemic or more symptomatic in terms of angina. And the higher the demand is, the same thing will happen. So this is a law of supply and demand. And these are some of the possible combinations of anti-anginal drugs that I use in patients with coronary artery disease. I mentioned already calcium channel antagonists, your nitrates, as well as your beta blockers. But there are some drugs that do not act in terms of lowering the BP or lowering the heart rate. These are the metabolic enhancers. They actually act more in the cellular level by creating a more favorable or a more efficient myocardial cell. Specifically, trimetazidine favors glucose oxidation and inhibits fatty oxidation. And in doing such, because of the more use of the glucose oxidation, more ATP is produced with less oxygen consumption. So that makes the myocardium more efficient. Ranolazine is also another metabolic enhancer, and this has a less well-defined mechanism of action, but it leads to reduction of your calcium levels through inhibition of the late sodium current. Now, we are all familiar with statins. I'm sure a lot of our listeners, I personally, I am using statin to lower the cholesterol levels. But more than statins, there are now additional drugs like ezetimibe and the most, or I would say the newest drug that is used to lower the cholesterol levels will be your PCSK9 inhibitors. No? Medyo mahaba. Pro-protein convertase subtilisin type 9 inhibitors. These are subcutaneously administered every 2 or 4 weeks, but the most recent one is only given twice a year, every 6 months. And they have been found to lower cholesterol levels even more than the use of statins. Another one is the bempedoic acid, but this is not yet available in our country. As I was saying, PCSK9 inhibitors like evolocumab and alirocumab, they have been shown to significantly reduce cardiovascular events in patients with established cardiovascular disease or those patients who just recently had an acute myocardial infarction. Again, I'm sure you have been familiar with the newer medications that are being used for diabetes. The SGLT inhibitors like empagliflozin and dapagliflozin, they have been found to also be beneficial in our patients with chronic coronary syndromes or CAD. But most recently, I think a lot of our patients are using this drug for weight loss, but it has also been proven to help our patients with chronic coronary artery disease in terms of lowering of major adverse cardiovascular events. As I have mentioned earlier, the new concept in terms of why patients develop myocardial ischemia, not only related to critical coronary artery stenosis, but other possible causes like inflammation. And in this slide, I, I am showing you the effects of anti-inflammatory agents in the control of myocardial ischemia. And one of the most commonly used anti-inflammatory drug in the management of chronic coronary syndrome or CAD is colchicine. You may be familiar, some of you might have gout and have used colchicine for pain control because of its ability to mediate chemotaxis and phagocytosis. It has been found that it can benefit patients with chronic coronary syndrome as well as acute myocardial infarction. And in the latest guidelines, both the European Society of Cardiology and the American College of Cardiology are recommending the use of colchicine with a grade of class 2A and class 2B in the American College of Cardiology. They may be considered to be used to reduce myocardial infarction, stroke, and further need for revascularization. So let's go now to some interventions that are very non-conventional. And as I have mentioned, I know I have some patients who have used chelation therapy. This will probably end up to be having a lot of discussions whether it's really beneficial or not. But I will just share with you the latest guidelines on where chelation therapy is. So what is chelation therapy? It refers to the use of intravenous infusion of EDTA. What is EDTA? EDTA is actually used in a lot of other function like a preservative, an anticoagulant, but it has been found to be beneficial in those patients with heavy metal poisoning. If you have a patient with lead poisoning or a cadmium poisoning, these are heavy metals, EDTA is able to combine with these biologically active heavy metals to form soluble complexes that can then be excreted. So it's a very good drug for heavy metal poisoning. But because of its ability to reduce calcium buildup, and we all know that calcium is a primary contributor to the formation of a vascular plaque, some studies have been done to see whether they are able to decrease cardiovascular events in patients with established cardiovascular diseases already. And one of the biggest trial to assess chelation therapy is the TACT trial. It is a 2x2 design, which means IV chelation and use of oral high-dose vitamins versus placebo for both IV chelation and oral high-dose vitamins. It did show some form of reduction of cardiovascular events, specifically in the patients who had diabetes. And the conclusion, though it was positive, however, the authors said that the TACT trial did not provide enough evidence to support the routine use of chelation therapy for the management of heart disease. The American Heart Association and the American College of Cardiology, up to this point in time, says it is uncertain whether chelation therapy is helpful as a treatment for heart disease. FDA has not approved chelation therapy, and it has its side effects, it has its known risks, but one of the most common risks would be the vein site burning where the medicine is given. Because of the positive result actually in TACT trial, TACT-2 was done, and specifically, this enrolled patients with diabetes and coronary artery disease. However, the results of TACT-2 did not match the result of the first TACT. TACT-2 trials showed no difference in clinical outcomes in patients with diabetes and established cardiovascular disease. So at present, because of these current findings, we do not yet, or the guidelines do not yet support chelation therapy for post-MI patients with diabetes. Now, the last few slides will be talking on shockwave myocardial revascularization, on external counterpulsation, and transmyocardial laser revascularization as additional interventions that may be offered to some of our patients with established coronary artery disease. So ESMR is available in our country. What does it do? This is the delivery of a low-intensity shock that exerts mechanical pressure and tension on the cardiac tissue. It has been found that it can lead to stimulation of angiogenesis-related growth factors and may stimulate the process that increases collateral growth, myocardial remodeling, and left ventricular compliance. I will share with you a video so that you would understand how ESMR is done.
Conventional treatments, including surgical and interventional methods, lead to only partial revascularization and repeating hospitalizations for patients with advanced coronary artery disease. There are also many patients for whom conventional treatments are not an option. Metaspec's clinically proven approach is complementary to existing treatments with the use of ESMR, extracorporeal shockwave technology for myocardial revascularization. Now, the CardioSpec ESMR is making all the difference, bringing hope for no-option patients. The CardioSpec system can be used in any medical environment, from small private clinics to large hospitals. Precision is top priority, as the treatment area is located by cardiac ultrasound imaging, while the shockwave applicator is positioned based on echocardiography findings. Utilizing low-intensity focused shockwaves, the CardioSpec stimulates microvascular angiogenesis, resulting in improved blood supply to otherwise ischemic tissue, increasing local perfusion and promoting healing. This state-of-the-art system is fully computerized, providing accuracy and control of the treatment procedure. The CardioSpec is exceptional in that it works with a large focal zone to achieve the optimal therapeutic effect, total transmural coverage, and speed up treatment duration.
Okay, so that's one non-conventional treatment, the extracorporeal shockwave. But the other one that has been used will be your enhanced external counterpulsation therapy. How does this work? This is an outpatient, non-pharmacologic, non-invasive therapy where we use ECG synchronized inflatable cuffs wrapped around the lower extremities to produce cyclic inflation and then deflation. It leads to increased venous return and augmentation of your diastolic blood pressure. Causes shear stress on the vascular endothelium that will allow promotion of angiogenesis and vasculogenesis. Again, the enhanced external counterpulsation has been shown to reduce angina factories. It has been shown to extend time to exercise-induced ischemia, decrease the dependency on nitroglycerin for frequent chest pain. It can increase maximum workload. And because of all of this, able to improve the quality of life in patients with symptomatic stable angina. And again, I will share with you how this works.
During EECP therapy, the patient lies on a treatment bed with large blood pressure-like cuffs wrapped around the patient's calves, thighs, and hips. EECP is timed to the patient's heartbeat. While the heart is at rest, the cuffs inflate in sequence from the calves to the thighs to the buttocks. Just before the next heartbeat, all the cuffs deflate simultaneously. For many patients, 35 one-hour treatments of EECP therapy results in decreasing their chest pain, fatigue, and shortness of breath. During inflation, blood flow increases to the vessels that supply the heart muscle. Oxygen-rich blood is increased by widening existing pathways, activating dormant vessels, and developing new arteries called collateral vessels. Rapid deflation of the cuff's pressure assists with unloading the heart supply to the body. This action decreases the workload of the heart. The enhanced blood flow throughout the body strengthens the lining of the vessels by expanding pathways and reducing inflammation. EECP results in improved circulation and an overall healthier cardiovascular system.
Okay, so that's the second non-conventional. At this point in time, it has been recommended with a level of 2B in patients with refractory angina and no other treatment options. It may be considered for relief of symptoms. And the last one is transmyocardial revascularization.
In transmyocardial revascularization, TMR, a surgical procedure for treating severe angina in patients with coronary artery disease, holes are made in the heart to improve blood flow to areas with poor perfusion. Here's a simplified explanation of the process. These channels penetrate the myocardium, the thick muscular layer of the heart. Blood flow enhancement. The goal of creating these channels is to improve blood flow to the heart muscle. By making openings in the heart tissue, it is believed that this can facilitate the delivery of oxygenated blood to areas of the heart that may not be adequately supplied. Blood flow enhancement. The goal of creating these channels is to improve blood flow to the heart muscle. By making openings in the heart tissue, it is believed that this can facilitate the delivery of oxygenated blood to areas of the heart that may not be adequately supplied. Angina relief. The improved blood flow can alleviate symptoms of angina, which is chest pain or discomfort caused by reduced blood flow to the heart muscle. It's important to note that TMR is usually considered when other treatment options have not been successful or are not feasible. While this procedure may provide relief, in
So transmyocardial laser revascularization is the surgical approach. This is an invasive approach compared to the first two ones. It has been studied in several randomized control trials. It is FDA approved. However, the study that was done did not show any benefit and a possible signal of harm. No, there's some complications associated with its use. The operative mortality range was in the range of 3% to 9%, a little bit high. And the 2012 ACC guidelines assigned a Class 2B recommendation to target or to transmyocardial laser revascularization. So in summary, I have explained to you the newer concepts and strategies that already defines the pathophysiology of CAD. As I have mentioned, it is not only exclusive for critical coronary artery stenosis, but there are other possible factors that can lead to myocardial ischemia and angina. I have shown to you some new drugs that can be used. So invasive and non-invasive means to further increase blood flow to ischemic myocardium. I showed you some videos on the extracorporeal shock wave, the external counterpulsation, and lastly, the transmyocardial laser revascularization that may be used in patients with refractory angina. Thank you very much for listening.
All right, thank you so much to Dr. John Anunuevo. Very helpful, very valuable po na learnings po natin, no? I will call you again, sir, to the Q&A later. At this point, we'll try to do a quick shout out lang po muna to those who are watching us. So there are those who are watching us from the Philippine Science High School in Cagayan Valley Campus in Bayumbong, Nueva Vizcaya, from Naik Medicare Hospital, Naik Cavite, May Kawayan Doctors Hospital and Medical Center, May Kawayan Bulacan, beautiful people from the University of Santo Tomas Hospital po, maraming salamat. The Philippine General Hospital as well, Philippine Pharmacists Association Incorporated, Baguio City in Benguet, Mindoro Occidental Premier Medical Group Multipurpose Cooperative in San Jose Occidental, Mindoro. Also those from the province of Bataan. From Batanes, meron po dito Cebu South Medical Center in Talisay City. Maraming salamat. From Bacolod City, thank you so much. And there are those po, no, also from Valenzuela Medical Center, University of the Philippines, Visayas, HSU, Miyag-Ao Campus, URS in Taytay, Rizal. Also, internationally, there are those joining us all the way from Algeria. If you could appreciate that, from Chonin Hospital in Taipei City, Taiwan, Ryan Hall Shanix Incorporated, Bridgewater, Canada, VRP Medical Center in Hillsborough Township, USA. Gorgeous people from Suta and Sarantis po. Maraming salamat for joining us this afternoon. Eastern Visayas Medical Center also here, and I think it's Mariano Marcos Hospital po, no, in Ilocos Norte, and Antipolo Cabading Hospital po. Maraming salamat. Okay, for our reactor today, as mentioned po, no, he is the chief of the cardiac characterization unit po, no, the cath lab at the UPPGH Department of Medicine. So please welcome to your screens Dr. Eric Oliver Season.
Hello, Sir Raymond and Ma'am Stella, and to all the viewers, and of course our speaker, good morning. So I'm tasked to give just a short reaction. Thank you very much, Dr. Anunuevo, for that a very eye-opening lecture, because it's not often that we get a lecture on alternative treatment options for chronic stable angina. So some points. It's very good that we understand that chronic coronary syndrome has really a very different. It's a very different animal from what we know from acute myocardial infarction. So patients with chronic coronary syndrome usually are stable, as mentioned by Dr. Anunuevo, and usually generally have better prognosis than ACS patients, but they are symptomatic. So the goal of treatment is actually quite different as mentioned by Dr. Anunuevo. For my personal take on the treatment strategies for these patients, they include the improvement of prognosis or pahabain ng buhay. Gusto nating pahabain ng buhay nila. And also to improve the symptoms and the quality of life. So paginhawain naman ng buhay din, ano? So pahabain at paginhawain ng buhay. And we have most of the proven therapy already. We're quite aware of these, statins, antiplatelets, and some invasive treatment, ano? But although we have this proven armamentarium, there are still unmet needs among these patients with chronic coronary syndrome. It has been shown that these patients, despite all the proven treatment, still have a worse prognosis. Ibig sabihin, mas maikli pa rin ang buhay nila compared to those who are normal. And of course, a lot of them, despite medical treatment and even with percutaneous intervention or even bypass, some of them still have symptoms. So there are still unmet needs. So I think the lecture of Dr. Anunuevo is very relevant because he told us that there are multifactorial mechanisms that may be causing the patient's symptoms as well as adverse outcome. And what we have now may not be answering or meeting all of these mechanisms. So it's very interesting to see evidences that are emerging for some novel therapies, which actually show quite great promise, like your SGLT2, your GLP-1 inhibitors, and your PCSK9, which has a growing body of evidence that they may be useful in improving outcome. Even old drugs like colchicine, parang merong new indication. But also very important in the discussion on treatment is to also recognize some of the treatments that has not been shown to be effective. There are still some entities that may be still promoting this treatment like chelation, ano, na so far as also from the lecture has not yet really been proven to have specific benefits. So my main take-home learning, I guess, for this session is that we need to remember that chronic coronary syndrome is a more multifactorial illness, and there are several mechanisms that we really have to address. We have to look at the patient as a whole and explore all of these mechanisms so that we can improve their outcome. And we have to learn how to prioritize the treatment based on the evidence that they are effective, they are cost-effective, and safe for our patients. As an interventional cardiologist, sometimes we might become focused on the more high-tech intervention like PCI, but we should not forget that a lot of our patients will actually respond very well with non-invasive treatment like your medicines, that Dr. Anunuevo mentioned. So we need to be really explore all of these novel treatment strategies. We have to make sure that we are covering all our bases and probably reserve the more invasive treatment for those patients who do not respond to your pharmacologic therapy and even lifestyle changes. So yun lang po, sa maging mapanuri po tayo sa mga evidence, sa mga sinasabi na treatment that are effective or cost-effective. And thank you very much, Sir John, for giving us this novel treatment. Natuto din po kami.
Okay, thank you so much, Dr. Eric Season. In the interest of time, we'll dive right into our Q&A. First question coming in from Dr. Stella.
My question is it's actually for Eric. What we notice now is that there are more patients now who undergo stenting rather than coronary artery bypass graft. What is your comment on that? Kasi ang dami ko nang nakitang ganung situations. Hindi na pala nagka-coverage ngayon. Mostly. What is your comment on that?
Hindi naman po. Probably one of the we have to also separate yung mga patients with acute coronary syndrome, ano, yung mga nag-MI, which is actually quite common in our country. And the treatment for this is usually nga angioplasty or PCI. So siguro that's why we see more patients undergoing PCI. Ano, it's very unlikely that they will undergo CABG in this setting. But dun po sa setting na sinabi na dinidiscuss natin ngayon, yung chronic coronary syndrome, some patients, especially those with very severe or multivessel disease, would probably need bypass, ano, especially if the lesions are not amenable to angioplasty. But because nga of the increasing improved technology and the proficiency of a lot of our operators, a lot of the lesions before that were not amenable to angioplasty are now possible to do. So siguro most patients would, of course, prefer something less invasive if it's equally effective. Ano? Pero meron pa rin po talagang subset na kailangan ng surgical treatment.
Thank you for your answer. John, you want to add to that or okay na?
Yeah. Very quickly, I think nobody wants their chest to be open. So that's the reason why a lot of our patients would still prefer the angioplasty, because it's just a small puncture sa arm pa, no? Now we're doing it to the radial artery, and it's very comfortable.
Thank you for your answer. Si Raymond.
Thank you, Ma'am Stella. For Dr. John and Dr. Eric, coming in from Dr. John Tortona, Joseph Tortona, about CoQ10. CoQ10 po ba ay relevant pa sa treatment ng CAD? Is it still prescribed for high-risk patients? That's, I think, one of the first questions that we have here in the Q&A box.
Thank you, Raymond. Eric, I'll take this na, no? If you don't mind. Actually, I'd like to appreciate the questions of Dr. Tortona. No? Maraming nandito sa ating chat box. And very quickly, sagutin ko na lang lahat nung natanong ni Dr. Tortona. Let's start with CoQ10. So CoQ10 is an antioxidant. And I think the fact that it's an antioxidant already puts its position in the possibility that it might benefit our patients with coronary artery disease. No? If you look at the various concepts of the possible causes of myocardial ischemia, yung antioxidant might have a place. Hindi na katulad nung dati na panay-baradong ugat lang yung cause ng myocardial ischemia. Unfortunately, Dr. Joseph, walang randomized big controlled trials. That's why it's not included in the must give to our patients with CAD. But I think it's a drug that is quite safe. And if your patient has extra finances to buy the drug, I will not argue with you if you want to maintain your patients on CoQ10 for additional benefit that it can offer, especially if it has established cardiovascular disease. Now, let me just go through this very quickly, Raymond and Stella. The questions on natural products, such as marine natural products. I think this is in reference to products that might have omega-3 fatty acids. No, our patients who are taking omega-3 fatty acids. Again, there are some benefits. There are some RTCs, randomized controlled trials on the use of omega-3 fatty acids already, as again an anti-inflammatory, an antioxidant, even an anticoagulant. So may mga reasons sila why it can be used. The last question that I think Dr. Joseph mentioned was the use of artichoke, garlic, niacin. I'm looking at all of these substances here, and most of them will have either an anti-inflammatory or an anticoagulant property and able to lower the LDL level. So it will have its role, I think, but again, unfortunately, no big, large RCTs have been done on these products that you mentioned, and they are not in the must-give drugs. But I don't see any problem. If you wish to give it to these people, just make sure that they are well informed, that they are not included in the guidelines as Class 1A recommendations or Class 2A. Thank you.
Right. Thank you so much, Dr. John. Ma'am Stella, do you have anything else? I think that
And no
should
more further questions. At saka our time is up.
So
Can
okay,
we have
we're
your last statement, the two
yes.
of you, si John muna and then Eric. What is
Okay.
your advice
Last
to our
reminders or
audience?
messages to our audience, sir.
Okay. So first, dalawa lang. The concept of myocardial ischemia has changed. Hindi lang po ang myocardial ischemia ay dahil sa baradang ugat. Marami po pong possibility. And second, if your patient is not responding to the conventional way, to the conventional drugs that we give them, you can use other non-conventional therapies. Thank you.
Eric?
Dr. Eric?
Sige po. I think yun lang din po, no? Let's prioritize yung treatment. Unahin natin yung mga treatment na proven to be effective and safe. And then kung talagang hindi pa rin po nagre-respond ang patient, maybe that's a time to explore some of the emerging novel treatment strategies.
All right.
Thank you.
Thank you so much. We'll take this opportunity also to thank our consultants po, no? From the Division of Cardiology at the Department of Medicine po, no? The UP Philippine General Hospital. At this point, we'll be launching our evaluation poll. It's 5 statements, 4-point Likert scale. We invite everyone, especially those who are in the Zoom, to participate po. No? I'll read through it, but we will not close this until the end of the episode. Number 1, the panelists demonstrated thorough knowledge of the topic. Number 2, the panelists were well prepared and organized. Number 3, the panelists spoke clearly and audibly. Number 4, the panelists used appropriate language with technical medical jargons adequately explained. And finally, the panelists contributed to new perspectives and knowledge on managing various key health issues. Maraming salamat po again, Dr. Anuevo, Dr. Season. In the meantime, you can still watch us on the playback at the TVUP YouTube channel and at the TVUP Signal TV channel 101. So, Dr. Stella, during our mini intermission po, as mentioned, that next week we'll have Dr. Antonio L. Danz. Dr. Danz is part of the evidence-based medicine group, also an academician from the National Academy of Science and Technology. So, we're very thankful, very fortunate that we'll be having him as our speaker for next week. Before we conclude our program, all health updates webinars are archived for viewing at the TVUP YouTube channel. So you just go to www.youtube.com/TVUPPH and go to the live tab. You'll be able to see all 242 episodes. After today, it will be 243 na po. Also, in the same YouTube channel po, no, you can go to the Shorts tab. I understand everyone very busy. We have some selected presentations that we feature in snippets po doon. It's at the YouTube channel. So we hope you'll be able to watch them at your convenience. Try to get nuggets of wisdom po for each of those short videos. Okay, so this formally closes po our webinar for this week. Magkita po tayo ulit next Friday from 12 noon to 1 p.m. It's a date.
Together, we can stop preventable deaths.
So keep safe, keep healthy, and see you online.